2. Okay, everybody has this PowerPoint. I just pulled it up on my Gmail because the Blackboard wasn't cooperating. Okay, so we're going to talk about this in lab. Okay, orders have to be written by a qualified legal provider. The orders for medications, like any other activity or intervention, are part of the medical record. Usually it is fact-checked by the nurse as well as the pharmacist. Okay. There are rare instances where sometimes medication bypasses pharmacy and they send up the wrong medication or the wrong dose. And unfortunately, we're the last line of defense to the patient. So it is very important that we also check for accuracy, okay? And if there's a question, we stop and we ask the question. I was giving medication with a student once, and I forget what it was. I think it was Lasix, furosemide, and there was an order to give 40 milligrams of Lasix once a day, furosemide once a day. And then I said, okay, before we pour this medication, let's just review everything on the list. I like to look at the whole list, just so I see what the patient is on. And then at a different time later in the day, there was another order for furosemide or Lasix, but a different dose. So we said, oh, is that correct? Are they doing that? Breaking it up like that, or is it perhaps an error? Maybe it was an old order and they forgot to discontinue it. So when in doubt, we called the provider, and sure enough, it was an older order that they forgot to discontinue. Okay, they must have started the patient on a lower dose, then they ramped it up to a higher dose, but they forgot to do. So pharmacy was still sending the medication to cover both times. And if the nurse didn't check, she may have given the patient too much medication, okay? So whether you give somebody too much or too little, it could conceivably be a medication error. So we always check, okay? And confirm allergies. Even if the allergies are written in a patient's chart, I'm just so type A, I'm going to ask the patient anyway. Or I may say, oh, I see they documented that you're allergic to penicillin. What happens when you take penicillin? Are you allergic to anything else? And then I'll still go through my list just to make sure that something wasn't missed. The checks and the rights we'll talk about in lab, and the 2 patient identifiers most commonly are the patient's name and date of birth, because that is what the patient hopefully is able to verbalize to you. If you need a 3rd identifier, you can go with the medical record number. Okay, sometimes it is rare, but sometimes we might get 2 patients on the floor with the same first name, and God forbid they have the same first and last name. Then we usually, we separate them. One is on one end of the floor, one is on the other, and different nurses, and we got to be super, super careful that we don't transpose orders. Yeah, so that's a challenge. Okay, so here's a question for you. A nurse is administering a medication to Mr. Brown. In addition to checking his ID bracelet, the nurse correctly verifies the patient's identity by performing which action? Are you going to say,
No.
you Mr. Brown?
No.
No. Are you going to read the name and sign above the bed if they have one? No. Are you going to ask the roommate?
No.
Definitely not. Okay. So here's your 2 identifiers. Okay.
D is correct.
Huh? D.
D is correct.
Yes, D is correct. So you see, something as simple as this can be enhanced a little bit when you're taking your NCLEX exam, but the concept is the same. If they added 3 more or 4 more choices, okay, and made it a SATA question, for example, they might separate name and they might separate date of birth. You know the answer, no matter if they give you 10 choices or 2 choices, you know its name and date of birth. So you know how to answer this question. Does that make sense? Okay, so don't be intimidated by the questions. All right, types of orders, I'll review them inside, so we don't gotta waste time doing it here. Here's
Professor,
another one, yes?
I'm very sorry. Last time I did the assignment in Prepue, here it says what are the 2 patients identifiers used to determine if the nurse is treating the right patient.
Okay.
And the answer was I choose name and medical record number. I thought that already the nurse knows the patients already, already asking just. But the correct answer, yes, name and date of birth. I knew it, but just I thought that the nurse has already verified. Because here it says the nurse is treating the right patient.
That's a medication, right? That's a medication, right? The right patient, right time, right dose. We're gonna talk about that in lab.
Just to throw you off.
Yeah,
It is the right.
exactly. Okay, so a PA, a physician's assistant, who's legally allowed to prescribe orders, orders a pain medication for a post-operative patient that has a PRN order. When would the RN administer this medication? Okay, so here's your lead-in. Okay, your lead-in is your provider orders a pain medication. The patient is post-op. That's just added information. The key here that the order is a PRN. Here is your key. Okay. So when would the nurse administer this medication? So what is the question asking you to do?
As needed.
To give you you have to know what PRN is.
Yeah.
Okay? So the pain medication is administered as needed for pain, a single dose during the post-operative period. Medication is administered as standing order, 1 dose of medication administered immediately.
Immediately.
No.
No.
It's needed.
Immediately it's stats, right?
Okay, we didn't review all of the types of orders, we're gonna do that in lab, but we do know PRN means what?
As needed.
As needed.
As needed. So, which choice
A.
answers that? A. Everything else is a distractor, it's for something else. Okay, so when you look at a question, okay, you read the question, okay, and then you go back and you reread it so you understand it, okay, this is the setup, okay. Then you ask yourself, what is this question asking me to do? Okay, just within the context of 2 sentences, what are they asking me to do? And then you already know that when would the RN administer the medication? We know that PRN is as needed. So this is what I'm looking for, as needed. PRN, as needed. It's not this, it's not a single dose. A single dose is not as needed. It's not a standing order, because a standing order is completely different. And administered immediately, that's not PRN. So it doesn't fit. Do you see?
Yeah.
There is a mechanism for dissecting questions, okay? I hope you took some tips away from the test-taking strategy so that you, instead of having anxiety when you see a test question, you say, okay, what do they want? Let me read what it is, and what do they want me to do? Just within the framework of that one question. You don't want to know anything else about this patient, because it doesn't matter. It's not germane to the question. Does that make sense?
Yes.
Okay, it's not necessary information. They only give you what you need to know. Here's another one. A nurse discovers that a medication error occurred. What should be, it's supposed to be the, not he, the nurse's priority response? Okay, so what are they asking you to do?
Priority response.
Priority. Okay, so is it complete an incident report, notify physician regarding the next course of action, check the patient's condition to note any possible side effects, record the error on the mark. What do you think is the correct answer?
C. I'm gonna check patient.
Yes, the first thing you wanna do is check the patient, okay? You wanna check for safety. Does that make sense?
Yep.
Okay. And then what would be the second thing you would do?
Notify.
Notify, very good. And then what would be the third?
Report.
Complete an incident report and then record the error. Yeah. So do you understand when we say priority, what does priority mean?
First thing you wanna
The
do.
most important thing, okay? Priority, the first most important thing you're gonna do. Okay, if it's priority, it's gotta be the most important, right? Okay. So oral medications, we talked about this, most common and convenient. Okay, we'll talk more about that in lab. This is just information that I've kind of mentioned before. We can give medications also enterally, either through an NG or the PEG. Liquid medications in that form are definitely preferable because why? We don't want the tubes to clot, right? Clog up. If they are solid pills and we need to crush them, we crush them individually. Okay. Has anybody seen medications being given this way?
Crushed, yes.
Oh, good.
Oh, not in the, no, just crushed.
Just crushed in like applesauce or
applesauce,
something?
yeah.
Okay, okay, but not, you haven't had a PEG or an NG?
No.
Okay.
on a G tube.
Huh?
That's on a G tube.
You did? Wonderful, wonderful, very good, very good. Okay. All right, there's a whole skill set that we teach you about checking for placement before giving it, and you'll have that in lab as well. Not today, but a different day, I think. Okay. Nursing considerations, these are the oral medications. We told you it has a slower onset, more prolonged, less potent. It's usually given for convenience. Okay, enteral, again, with these folks that either have a PEG or an NG tube, you want to elevate the head of the bed because you don't want the patient to have reflux. What's reflux? It comes up, right? It comes up, okay. But before we give medications this way, we have to always assess it. So we will teach you how to do that in the lab, okay? You have to assess to make sure that it is in the right place that it's supposed to be. And if you pull back on fluid, you will see more of a grassy greenish, which means it's in the right place, it's in the stomach. Sometimes it can curl and it can get relocated, so that's the reason why we check before we give any medication. And this again will teach you how to do that in the lab. These are just steps, but I'd rather you see it first and then you look at the steps, because if I just explain something to you and you're not being able to see it, it's going to be a little bit more confusing. Basically, like I said before, you're going to ask for liquid forms of the medications if at all possible. You're going to sit your patient up, you're going to check for placement, and you're going to give one medication at a time, okay? You always flush when it's a little PEG tube or an NG tube. And the reason for the flush with lukewarm water is because you want to maintain the patency of that tube. Does that make sense?
Yeah.
Okay. But again, we'll show you. Sublingual, under the tongue, okay, we just ask the patient to open their mouth, lift up their tongue, and we place the medication there. It's designed to dissolve once they close their mouth, okay? They don't need to swallow, chew, or drink any water, just let it dissolve. Buccal, again, is between the cheek and the gum. Sometimes medication goes there. It's according to the mechanism by which the medication or the drug is released, what's best. Okay. Here's a nice little SATA question. The nurse is administering a medication to a patient with an enteral feeding tube, which are accurate guidelines related to the procedure. Select all that apply. Okay, so how do we answer a SATA question? True or false? So let's do it that way, okay? A, crush the enteric-coated pill and mix in the liquid.
That will not be a crash.
So that's false. So forget it, it's off the table. Use the recommended procedure for checking tube placement in the stomach.
Yes.
Yes, we're taking that, okay. Flush the tube with 60 mLs of cold water before and after.
False.
False, never cold, we use room temperature or a little warm. Give each medication separately and flush with water between each drug.
True.
True. Lower the head of the bed to prevent reflux.
No, false.
No, that's false, okay? Does anybody have any questions with that question? That was fairly straightforward, right? Okay, good. Transdermal we talked about, okay? Putting it on rotating sites so that it can be absorbed through the skin. We always use what when we give this? Gloves, okay, gloves. Here's the nitro paste that I picture the nitro paste I was talking before. It's just a small little piece of paper and the nitro paste comes in a tube and we literally just squeeze the amount on to measure it and then we place it on the patient's arm or chest. Before we do that, we take off the old one, right? Okay, and this is another type of transdermal. She's putting it, or he's putting it on almost like a Band-Aid, but you note that there are gloves, okay? And when you're taking the old one off, you want to fold it in half so that when you do dispose of it, it lessens the chance of somebody coming in contact with the medication. Okay, that's just as a courtesy. All right, good. Drops, eye drops, any installation or irrigation. We're gonna cover this a little bit more when we talk about the eyes, okay? We wanna be able to control intraocular pressure. That's what IOP is, okay? So a lot of times, folks may have glaucoma and you'll have maybe 2, maybe even 3, sometimes different eye medications to put in them. If anybody has ever had a eye infection, you may have had an antibiotic eye drop put in, or maybe even an ointment. Okay. Ointment kind of blurs the vision a little bit because it's more greasy, but again, different, drugs come in different forms and it depends what the provider orders. So basically it's just outlining how to give an eye medication. You're going to learn that also in lab. Always wear gloves. Again, you might come in contact with somebody else's mucous membranes and you don't want to do that. And you don't want to give the patient anything. So you always wash your hands, don your gloves, explain to the patient what you're doing. That's for anything, right? And then you would proceed, okay? Have some tissues with you and make sure, we'll learn in lab, you do the 3 checks to make sure you have the right medication. To the extent possible, you're gonna ask the patient to tilt their head all the way back. Why? Because it promotes the retention of the liquid in the eye. And then you would pull down the lower eyelid and you would put it right in that little groove or trough that makes. You would plop it in. You don't drop it on the eyeball. You drop it inside the lower eyelid. And then as soon as you put the drop in, what does the patient do? They blink because it's a normal reaction, right? There's to a stimulus. So that's why you have the tissue ready in case, some of the medication runs down the patient's cheek. After each drop, you give the patient, you know, a minute or two to let that medicine absorb. Sometimes it's in both eyes, so then you do one and then you do the other. You have to go back and do it again. You know, you're giving that patient a little bit of a break. The eye dropper itself in the vial, do not let that plastic touch the eye. You can actually bruise their eye, okay? So you have to make sure it doesn't touch the eye. And when you take the cap off of something, whether it's ointment or it's a liquid bottle, what do we do with the cap?
Try not to
You
contaminate
probably
it.
won't hold it because you're busy administering.
Try not to contaminate inner part of.
So how do we put that down? How do we put it? You put it on its side. You put it on its side. You don't just take it off and put it down, okay? I usually put like a tissue down as my little workspace, and when I take it off, I just lay it on its side. Okay, so you don't want to contaminate the inside of the cover, right? Because then it's going to get onto the bottle itself, okay? And then you always ask the patient how they feel afterwards, okay? Irrigations, ointments, same thing with an ointment. If you're doing bacitracin or something into the eye itself, the rule of thumb is to squeeze out and discard the first bead or part of the ointment that comes out of the tube. Why? Because it may be contaminated. So the first bead, you just squeeze it out and get rid of it, okay? And the same mechanism applies. The patient has their head back. You're going to pull the lower eyelid down, and you're just going to line the rim of the lower eyelid with the ointment, okay? And then they'll close their eye and keep it closed for a while so that the warmth kind of allows that ointment to spread over the eye. Now, it could give them a little bit of blurry vision afterwards because it's greasy, but that's okay. You're not going to have them do any type of activity when you're giving eye ointments. And any eye irrigation, that would be usually to remove a foreign substance or potentially to just soothe or bathe the eye. Ear, we talked about ear, okay, and there's a mechanism for that, so we'll teach you that. Basically, the auricle of the ear has to be positioned to straighten the canal in order for any ear drops or irrigations to occur. So for the adult, we take the tip of the ear and we pull it up and back. That straightens the canal, okay? For peds, it's different. It's usually down and back because they have a shorter eustachian tube. So that's the first and main thing, is to straighten it out, and then you irrigate or add medication as it's ordered, okay? Are we going to have the patient on the affected side or the unaffected side when we're doing
Unaffected.
the unaffected, right? Because you want the medication to stay in the ear for a little bit. And sometimes they may say put a little cotton ball in afterwards. Okay. Nasal irrigations, we've all done this, okay? Anybody that has used any type of nasal spray. How we would do it to ourselves is exactly how we would do it to the patient, okay? Again, you have your hand hygiene and your gloves, and you're going to instill the amount of sprays that are required by or if the patient is able to do it, you just give it to the patient and let them do it, okay? And they can give you the medication when they're finished. Vaginal application usually requires a applicator, and before you put anything in a woman's vagina, you want to make sure that they're comfortable, pain-free, and that they have voided okay, because you want them to be able to
Hold it.
hold it, exactly, and not accidentally, push it out when they're urinating, okay? And then, of course, before you enter anything, you always want to make sure that their perineal area is clean, all right? You don't want to accidentally introduce any bacteria, okay? Rectal installations, okay, if you're giving an enema, again, we'll teach you how to do that in the lab. Same thing, hand hygiene, gloves, and I would put on PPE, okay? I would definitely put a gown on because you never know. It's always better if the patient can turn on their left side because it's just for ease of installation of the fluid, okay? Left side is the best. And again, lubricate the tube before you insert it into the rectum because you don't want to traumatize. The tissue is very delicate there. And we'll want to show you how to do that. Inhalation, we're going to go over that in the lab as well. This is basically an inhaler. So medication is delivered to the lungs either with micronized particles or aerosolized. Those are the two mechanisms by which we can give medication directly to the bronchial tree. So we'll show you how to do that in the lab. Anybody that has ever had or knows somebody that used an MDI, metered dose inhaler, or high flow inhaler, maybe you can answer this question, or let's try. All right, a nurse is teaching a patient how to use it to control asthma. What are the appropriate guidelines for proper administration of this device? Select all that apply. Okay, so they're giving you, even if you don't know what this is, metered dose, it's something that's inhaled. So inhaled is breathing, so that there's a little clue right there, okay? Asthma, so you know you're definitely dealing with a respiratory illness. And what are they asking you to do?
Correct or wrong when it comes to
What do you do, okay, when you're giving it, okay? Select all that apply. They're not telling you to put it in order, they're just telling you what do you use, what do you do? So again, SATA, true or false? A, shake the inhaler well, remove the mouthpiece cover from the device. Yep, it's true. Take shallow breaths before inhaling the medication. That's false. You want them to take deep breaths. Depress the canister, releasing one puff, and inhale slowly and deeply. Yes. After inhaling, exhale quickly through pursed lips.
No.
You want them to hold that medication for at least 10 seconds, 5 to 10, okay, as long as possible. Wait 1 to 6 minutes as prescribed before the next puff. Yes, because again, you want to give the body a chance to acclimate and let that medication work. Gargle and rinse with salt water after each use.
No.
What are you doing?
you brush your teeth.
Or you can just rinse with plain water.
Yeah, but not
Okay?
salted.
It does not need to have salt in it. And does anybody know why we rinse out the mouth with water?
Because of the residue.
Yeah. There is some residue that may adhere to the inside of your cheeks or your tongue, and that can cause, over time, a condition called thrush or hairy tongue. Okay, and that is usually like a type of fungus. So then we'd have to give the patient another medication to eradicate that. So we just have them rinse their mouth out so that avoids that happening. Okay, parental. Hopefully we can cover this in lab today as well. Parental is given by injection. So there are different angles, sizes of needles, and even types of syringes that you would choose when you are giving a parental medication, okay? So we'll teach you that inside, and even if you're giving, say, something like insulin or heparin that might be given subcutaneously, do we rotate sites?
Yes.
Yes.
Always. If we're giving an IM medication, do we rotate sites?
Yes.
Yes. We always rotate the injection site. Doesn't matter what angle or what type, whether it's a sub-Q or an IM, we rotate. And why do we rotate? Yeah, we can get scar tissue. Okay, and when we get scar tissue, it becomes very, very hard and dense. So if we keep going in that same spot with every single injection, the rate of absorption would not be effective because of the scar tissue buildup. So we rotate the sites. Okay, so we'll teach you how to do that inside. There's different syringes, there's different needle lengths. The length of the needle, it depends on the depth of the syringe. Okay, so longer needles for IM, shorter needles for sub-Q. Okay. Intradermal is a type of injection, and it's basically right underneath the skin. It's maybe 5 degrees, or at most 15-degree angle. Basically, you're creating like a little bleb. It looks like a mosquito bite on the skin, because if a mosquito bites you, it's biting you intradermally. Okay, so you have that little bleb, and that is for specific types of interventions. For example, testing for PPD. Now they do the quantiferon, but before it was the intradermal, and they made a circle around it, and you had to go back in 72 hours and have it read. They also do this if they're testing somebody for allergies. So what they do is they introduce a small, very, very small amount of the allergen under the patient's skin intradermally and watch to see if there's a reaction. Okay. So there's certain syringes. This is a tuberculin syringe, needle, gauge, okay, and angle. Sub-Q is a little bit deeper, okay, and we'll talk about that. There's certain sites where you can give a sub-Q medication. We have pictures for that. Again, outer aspect of the arm, the abdomen, the anterior part of the thigh, and also on the upper back. And it's very interesting because depending on where you are giving the subcutaneous injection and the patient's presentation, sometimes areas might have more or higher absorption than others. So that's why we give you so many different sites to choose from, because yes, you have to rotate, but also because of the absorption rate. Okay? And again, it depends on the angle and the length of the needle, and also the body fat of your patient before you give an injection subcutaneous. Okay, so here's a picture of the sites. See, here's the arm, the abdomen, the thigh, and also the back. Okay. We'll go over all of that. All right, let's see. A student nurse is administering heparin 5,000 units subcutaneously to a patient. That's a standard dose. Which statement, if made by the student, would indicate a need for further instruction? So tell me about this question. What are they asking?
What question, what answer is wrong? Which one is wrong?
He's doing wrong and he needs to educate.
Yes, so you need to select the wrong answer, okay? The wrong answer, because she needs further instruction. So let's look at this. A, I will aspirate before I give the medication. B, I will not massage the site after I give the medication. C, I will administer the medication 2 inches around the umbilicus. And D, I will not aspirate before I inject the medication.
A, I will.
Very good. Very good. Very good. So that's the wrong answer. Okay, good. You guys know. Okay. Intramuscular or IM. Okay, this is where you are injecting where? In the muscle. In the muscle, okay. So you gotta be a little bit careful because there's a lot of blood vessels in the muscle, okay, and also it is deeper into the skin, correct? So the needle has to be longer in order to reach, okay? The needle is anywhere between 5/8 to 1.5 inches. And we usually will use anywhere between a 1 and a 5 ml syringe. It depends how much volume we are giving. Intramuscularly depends on the site. So these are the sites that we teach you: ventrogluteal, vastus lateralis, and the deltoid. Where is the deltoid? It's on the arm. Very good. And then you have the vastus lateralis.
The thigh,
Right, on the thigh, good, and ventrogluteal is around this area, okay? Very good, very good. We'll show you inside, okay? We do not aspirate when we are giving an IM unless it's something really with large molecules like penicillin. But normally we do not aspirate. After the injection is given, we no longer massage. We used to massage, no massaging anymore. And we use a Z-track method to help the medication stay sealed in the skin, so we'll show you how to do that in the lab. Okay. And these are the sites. Deltoid right here, ventrogluteal, that's how you do your landmarks, and here's your vastus lateralis. The Z-track here will show you, it's better to show you than tell you, but basically you're pulling and displacing the skin, giving your injection, pulling out your needle, and then allowing the skin to go back, and it kind of seals in the medication so it does not leak out of the subcutaneous tissue, and we definitely do not massage. Okay. Same with the ventrogluteal. It's easier if your patient can lay on their side, but they don't have to. It tells you how, and this is the vastus lateralis. Okay. Deltoid. A patient in the hospital is to receive a medication intramuscular IM route. Which technique is recommended? A, the nurse selects the largest gauge needle for the site and medication to be administered. B, the nurse applies vigorous pressure in a circular motion to distribute the medication to the intended site. C, the nurse uses the Z-track method to prevent leakage of medication into the needle track. Or D, the nurse injects the medication into a contracted muscle to reduce pressure and discomfort.
C.
C. Very good. Use the Z-track method. Okay. So some nursing considerations here. Of course, it's very, very small, small print. So I'll see if I can't make it a little bit bigger. Let's see. No, it seems to make it smaller. No, forget that. Okay. How's that? Getting a little better?
A little bit, yeah.
Okay.
A lot better.
Alright. So, some nursing considerations. I told you before, rotate the sites. Okay, always rotate the sites. You don't do anything until you do your food checks, which we'll go over in lab. Of course, selecting the appropriate equipment to do the injection is very important. Clean the vial, we'll teach you all of that. okay? You inject air into the vial, the same volume that you wish to withdraw. So if I'm taking out 1 ml of medication, I'm gonna inject 1 ml. And that's just as a displacement so that the medication can come back into the syringe. But you guys are gonna need lots of practice, even just safely handling a syringe, because it's a skill. And you don't want to get what? Stuck. You definitely don't want to get stuck. If you're gonna get stuck with a needle, you get stuck with a clean needle. You do not want to get stuck with a needle after you have injected your patient. I can't tell you the amount of paperwork that's involved. That's also an incident report, okay, if you get stuck. You have to go to the emergency room, you have to go to employee health, you have to fill out all sorts of paperwork, okay? It's a big deal, so you don't want to do that, okay? All right, let's move on. All right, so IV, either push or piggyback. This is where you are injecting medication directly into somebody's bloodstream. So this is a very serious route of medication, and it's designed because you want a faster response, okay? But because you get that faster response, once you inject it, you can't take it back. It's in there, it's done, it's finished. That's why they say it's the most dangerous route, okay? So you need to be very, very careful. What's the first thing you need to know about somebody that needs an IV push or piggyback medication? They need to have a working IV, right? What happens if the saline lock or the IV is not in the vein?
It's gonna go to underground.
It'll go someplace else, right? It'll go into the tissue,
Right.
into the muscle, wherever that IV saline lock is sitting. But it's not going where it's supposed to be, in the vein. So we teach you how to check for proper placement, okay? One thing you can do is definitely look at it. And if it looks like it's old, if the dressing's falling off, if the intracap is half out of the extremity, if it looks obviously swollen, infected, draining pus, are you gonna try and push or piggyback any medication in there?
No.
Nope. You're gonna take it out. You're either going to start a new one, or you're going to call the IV team if they have one to place a fresh saline lock. And then you can test it to see if you have a blood return, and then you can give your medication, okay? So if we are piggybacking or hanging another medication to a line that's already running, okay, you want to make sure that that IV is working. If it's just a PEP lock or a saline lock, so it's just access, we call it access, but it's capped, so nothing is running in it, you would need to aspirate to see if you have blood, flush it to make sure that the liquid goes in smoothly and the patient does not feel any pain or discomfort. Then you can give your medication, and then you will flush it again, okay? Pretty much the same thing that you would do for somebody with what? An NG or a PEG tube, right? You assess it, you check the placement, you would flush it, give a medication, and flush it again. Exactly the same process, okay? So you see there are some commonalities. All right, let's look at this question. Dr. Jones has ordered hydromorphone, 2 milligrams intravenously, IV push, Q 4 hours, PRN for Mr. Byrne. The nurse notes Mr. Byrne is allergic to hydromorphone. What would be the correct procedure for the nurse to follow in this situation? So you see this beginning sentence, Dr. Jones has ordered 2 milligrams IV, ba 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 ba.
He's allergic to it.
All you need to know is a medication is ordered and the patient is allergic. That's all you need to know. So you see, I just picked out 2 words. Okay, IV, allergic. What would be the procedure to follow? So the question is asking you what?
I'm gonna call the doctor.
No, what is the question asking you to do?
Correct answer. What are you gonna do? What are you
Your
gonna
action,
do?
what you're going to do. What are you going to do? What is the nurse's correct procedure to follow when she or he discovers that the patient is allergic to a medication that was prescribed? What do you do? Do you
Call the
A,
doctor.
give the medication
No.
because
No.
Dr. Jones ordered it?
No.
No, because it's even though he ordered it, you have to check it, okay? It's not correct, so go on with A. B, ask the supervisor to give the medication. What's the supervisor got to do with it? Nothing, it's a distractor. Call Dr. Jones to change the medication. Yes, you have to alert the provider that the patient is allergic. Ask the pharmacist to dispense the medication and place it in. No, they can't do that. Right, because a pharmacist cannot prescribe. They're experts at knowing everything about the medication, but they can't prescribe for you. Okay, good. The medication order reads morphine sulfate, 2 milligrams IV push every 3 to 4 hours, PRN pain. Okay. The pre-filled cartridge is available with a label reading morphine sulfate, 2 milligrams per ml. The cartridge contains 2 mLs. What should the nurse do? So that's a math question. A, give all the medication in the cartridge because it expanded when it was mixed and this is what the pharmacy sent. That makes no sense. So we get rid of that. Call the pharmacy and request the proper dose. Well, would you do that? Maybe it doesn't come any other way. Let's look some more. C, refuse to give the medication and document the refusal in the EMR. Okay, on what basis would you refuse? No, so that's a no. D, dispose of 1 ml before administering the drug. Verify the waste with another RN.
Yes.
Okay.
It's your example just to be able.
Correct. So is D, do we understand?
Yeah.
We have any questions about this question? We're good? Okay, very good. All right, is that it for this one? Easy peasy. All right, I can move on. Let's see if we can, how much time do I have? Do I have time?
No.
No. All right, so we'll do